Okay, so تفضل.
Hello, good evening, everyone. This is Dr. Majid Rabelan. Under the umbrella of Saudi Ophthalmology Society, we would like to welcome you all to this evening webinar, which is the titled Shedding Light on Leber's Hereditary Optic Neuropathy. In this evening, we have a great speaker, Dr. Nouran Badib. She is a colleague from Jeddah. Dr. Nouran is an assistant professor in neuroophthalmology and other strabismus. She got her degree from University of Ottawa. We decided about this topic because there are some new things that we would like to share with you as a colleague ophthalmologist, as some patients are getting lost in diagnosis, and we will deliver to you some great news with the support from the Gen2 company helping us to order the genetic test, as it's the main issue that we have as an ophthalmologist.
Thank you, Dr. Majid. So first of all, I would like to thank the SOS of thinking of me as a speaker. I'm very honored to be here with you today. Also, I would like to thank the sponsoring company Biologics, because they've always been supporting for the patients and for us as physicians with regards to the diagnostic journey. So thank you very much. And if we are ready, we can start. Yes?
I believe so.
Okay. So as you said, Dr. Majid, most of those patients who are diagnosed with LHON, they have they either are diagnosed with malingering, because at the first presentation, they might have nothing except of the vision loss, and people would just mark them as functional or just malingering patients. And that is very a very severe accusation, because the parents might just like say, yeah, they're malingering, and then at the time when they are as adults and they can go to the ophthalmologist by themselves, it's too late. So this is what we're trying to do today, just to make the awareness about the LHON more prevalent, and just to have that diagnosis at the back of your head, especially when you do all the investigations in a young patient with bilateral vision loss, and they are all normal. So you just have to keep the LHON at the back of your mind. Okay, so let's start. We're going to talk a little bit about the demographics of this disease, mutations and testing, the clinical presentation, investigations, and updates in management. So this is Theodore Lebers. In the 1871, he's the one who discovered this disease and first described it. It's a maternally inherited disease of the mitochondria. And we are going to talk about the mitochondria later on, and the role of the mitochondria in the death of the cells if it's not generated well. The prevalence of the disease is 1 to 30,000, 1 to 50,000. So it's not that prevalent. So the new information that I discovered, that if we take 1,000 normal population, healthy population, and we test them for the mutation, one in those 1,000 population will actually have the carrier mutation. Is it cost effective to do like a screening, like a genetic screening for this mutation? I do not think so. It's not cost effective, because only 1 in 30,000, luckily, only 1 in 30,000 will develop the disease, if any. And some people will just be carriers for life. Most affected are males in their second or third decade of life. We also have childhood onset, less than 12 years, late onset defined as onset of the disease more than 45 years. But those extremes are rare. So most of the patients present in the second and third decade of their life. Well, it's never too late to have Leber's. So this is the oldest patient with Leber's, diagnosed at age of 87 years old. And I believe the youngest in the literature was diagnosed at 2 years old. So we should also keep the diagnosis of Leber's in those age groups at the back of our mind after we do all the investigations. Traditionally, we thought it's just a male disease. So traditionally, we thought it's a 5-to-1 male to female ratio. A new study of demographics of LHON in the American Academy of Ophthalmology found that the ratio has been updated to 3-to-1 male to female. And in extreme ages, as we said, the pediatric age and the age of adulthood, or more than 45 years, the ratio almost equalizes to 1-to-1 male to female ratio. So we also have to kind of like think of this disease, even if we have a female patient. Of course, after we think of demyelinating disease, number one, then we do all the investigations that we're going to talk about today. Then we think about Leber's. This basically just says that LHON can be sporadic in 44%. So negative family history does not mean that we do not think of LHON. So we always have to keep it in mind, even if the patient says that there's no family history of LHON. So it's mitochondrially inherited. So the female carrier or disease can transmit this to her offspring. So all offspring of a female carrier or diseased will have the carrier mutation. The father, if he is affected, so male patient carrier or affected, cannot transfer this mutation to the children because it's carried in the mitochondria in the oocyte only. Another thing when doing the counseling for the patients, we have to be very, very, very sensitive about choosing the wordings, because if we say, yeah, it's transmitted through the mother, we have to choose the word, the correct words when we're talking to the mothers, because most of the mothers, either they do not want to get tested because they do not want to be incriminated that they are the ones who transferred or blamed as transferring this blinding disease to their children, or they are tested and it's positive and they live with this shame of that they are the ones who are responsible for the blinding disease of their children. So we really have to be very careful with the counseling session with the mothers and the parents. Let's talk a little bit about mutations. So we do have more than the 3 common mutations for Leber's. I'm not going to go through those, don't worry. But we do have top confirmed LHON mutations from the LHON mapping website. And we do also have new variants that we discovered by doing the testing. Over 90% of the cases that we know fall into those 3 mutations. So it's the 11778 mutation, 3460 mutation, and the 14484 mutation. And those are the mutations in complex 1. And we're going to mention what is the importance of complex 1 in the mitochondria. So you have a patient and you suspect that this patient has Leber's, and you do the mitochondrial targeted for the 3 common mutation, it's negative. What can we do? So then we test the whole mitochondrial DNA to detect any new variant or the rare mutations, which account for 5% in the LHON population. What if it's negative? No, I have a surprise for you. It might change the paradigm or change some of the questions in the board questions. But so we suspect that this patient has a phenotype of Leber's and the mitochondrial DNA is negative. We will do a WES, which is whole exome sequencing. Why am I saying this? I'm going to leave this for a second so you can digest it. So my reaction to this article last year when it was published, I'm like, wow, impaired complex 1 repair causes recessive Leber's hereditary optic neuropathy. So autosomal recessive LHON, not mitochondrial LHON. How so? So they had the population of, excuse me. So they have a population of 33 persons who tested negative for the mitochondrial DNA. So they said, let's do a WES to discover what might they have. And they discovered that those patients had the recessive Leber's hereditary optic neuropathy. So the phenotype is indistinguishable from the mitochondrial disease. Its estimated prevalence is less common than the mitochondrial, so 1 to 1 million. As we said before, the mitochondrial 1 to each 30,000. And then male predominance, 10 to 1 ratio. Age of onset is younger than the mitochondrial DNA patient affected. And the mutation is in the nuclear gene DNA JC30. So this gene plays a role in the complex 1 repair in the mitochondria. The good thing is that higher recovery rate, better response to idebenone. Another study was mentioning a 47-year-old woman who had the phenotype of LHON negative mitochondrial DNA testing. And then when they did the West, they found that she has an autosomal dominant LHON. So this is kind of a new thing. We still say that majority are mitochondrial, but just as an update for you guys that yes, it might be inherited as autosomal recessive more commonly, and then yeah, maybe case reports autosomal dominant LHON. So the good thing here in Saudi Arabia now, Biologic Diagnostic Program is offering a free testing for the mitochondrial DNA. If you have a patient who you suspect that this is a patient of Leber's, you can just give them a call. This is their information, and then they will provide you with a card, which is this. You have to fill in the consent, fill in the patient information, what are you suspecting, and just fill those circles with some blood from the patient and call them. They will come and collect the sample, and then you'll have the results after 25 days. So it's really great because it's free. We love stuff that are free for our patients. Let's talk a little bit about the pathophysiology. And when we talk about the pathophysiology of a disease of the mitochondria, we want to know what is the role of the mitochondria in the retinal ganglion cells. So it is the energy powerhouse of the cell. It regulates oxygen species, and it regulates the process of the apoptosis or the cell death in the retinal ganglion cells. So any disruption in the mitochondria will signal the cell to die. So this is what's happening in Leber's. Talking more about it, how do we get the mitochondrial dysfunction in LHON? So normally what happens is that if you can just pay attention to here, can you see my mouse when I move it? Yes, no?
Yes, it's seen.
Yes,
yeah.
Okay. So we have the complex 1 here, which the LHON mutations fall into. Normally, the complex 1 transfer electrons to complex 3. The end result is production of ATP or energy for the cell. What happens is we have a mutation, complex 1 is defected. So the electrons are accumulated here. They react with the oxygen and create reactive oxygen species. Reactive oxygen species will signal the cell to die. This is what happens. And then at the end result, which is the ATP, we do not have ATP because the process has stopped here. So we don't have energy for the cell. Also signals the cell to die. So this is what's happening in Leber's. So the patient from being carrier of the mutation gets affected and manifests with the vision loss. So we're talking about the retinal ganglion cells. The patients with Leber's will present initially with the affection of the central vision and papillomacular bundle affected. And we might also have a sequocentral scotoma from affection of that area. So what's happening? Why is this area initially affected more? Because in this area, we have small, very small midget cells, and those have small bodies, and they have small dendrites. So they have more oxygen demand, and they are more susceptible to any damage from reactive oxygen species. So that's why we have at the beginning the affection of the papillomacular bundle, giving us the sequocentral scotoma, the central scotoma. Of course, risk factors for the carrier to get to be affected is smoking alcohol, because they increase reactive oxygen species and triggers the cell death for the mitochondria. Dr. Majid, did you want to stop here, or should I continue to the clinical presentation?
Yeah, Dr. Nuran, just a few points that we can discuss with the audience is what we have learned from the first part of your lecture is that Leber's hereditary optic neuropathy is mainly a mitochondria disease that affects young, both male and female, not only males. There was a strong belief among general ophthalmologists that because it's mitochondrial, it's affecting males, but in reality, it affects both genders. The second lesson that about the new era of having a very rare LHON with autosomal recessive and autosomal dominant Leber's like hereditary optic neuropathy. That was the second information that we got. And the third, most of us, if we read the textbook in ophthalmology, we do hear about the common 3 mutations, but in reality, you highlighted clearly that we have more than actually 1 mutation, more than the 3. And you highlighted clearly that we might sometimes need the whole exon sequencing to find the unusual type of mutations. And the fourth point is you talked about why patients with the hereditary optic neuropathy show the mutation, and you talked about the pathophysiology of the complex 1 within the mitochondria, and you mentioned clearly that the main issue here is not lack of ATPs, but the peroxidation level, that the oxygen species kills the cells. There were like many ongoing research over the years looking at the aspect of why Leber's patients have a problem with their mitochondria, and you highlighted clearly that is the oxygen species, and this will help later when you talk about the treatment modalities for this pathology. Thanks for these clear points. I think we can now move forward to the clinical presentation, and please, for the all audience, if you have any question about the first part, write down your question in the question and answers section.
Thank you, Dr. Majid, for summarizing the first part of the lecture. And let's move on to the clinical presentation. So you have a patient who's a young patient with subacute vision loss in one of the eyes followed by the others, or bilateral vision loss, who presented probably late. And you do the examination. Usually we have this characteristic appearance of bilateral disc swelling, and we have the tortuosity of the blood vessels, telangiectatic blood vessels at the peripheral area here at the disc margin. Not all patients present with this picture. Some patients present with normal optic disc, as we can see here. So those patients, sometimes they are also diagnosed as they are malingering. And if you have the patient presenting late at your clinic, you might see also that he has the temporal pattern already manifesting. So what about the swelling from the LHON? What's that? Is it a true swelling or a pseudo swelling? So it's not a true swelling. And if we do an FFA, we have no leakage. So we know it's not a true swelling. And researchers highlighted that and tried to understand why do patients with LHON have disc swelling. And they think that it's might be because the energy deficiency at the disease onset may cause compensatory engorgement of the vessels around the disc, which could lead to RNFL thickening. So that's kind of the theory from it. What is the rate of bilateral involvement in LHON? So at the same presentation, patient coming with both eyes vision loss, we thought in the classic teaching that it's a unilateral disease followed by the other eyes after 6 weeks. However, we should consider it still if the patient presented with bilateral disease, because it's 50% of those patients present with bilateral disease at the same time. Another thing to keep in mind, do not dismiss the diagnosis of LHON if the patient presents with unilateral disease. And years after that, he presents with the other eye getting involved, because that's also reported in the literature. Of course, we have to think of demyelinating disease in this case first, and then do all the investigations. And at the end, if we don't have anything that's positive, then we think of Leber's. This is our typical presentation of LHON. This is a case that I saw during the fellowship. He's a 38-year-old male presented with subacute gradual painless loss of vision in the right eye. He had family history, maternal uncles having vision loss, and he smokes and drinks. He presented with a vision of 20/150 in the right eye and 20/25 in the left eye. Both eyes were affected in terms of the color vision, so 13 out of 16 in both eyes. As you can see here in the color fundus photo, that he has bilateral mild disc swelling with tortuosity of the blood vessels and some telangiectatic blood vessels at the disc margin. And in this patient, we thought he presented with unilateral disease. However, the surprise was when we did the visual field. As you can see here in the left eye, he started to have those central scotomas. So we could say that, yes, he started to manifesting LHON even in the other eye, despite him not being symptomatic. The RNFL, as you can see here, when you take a look at it first, oh yeah, it's all green, the numbers are okay. But when you kind of like look closely at the superior temporal, inferior temporal areas, you can see that it's swollen a little bit. So that's kind of a hint that RNFL might give us some hint about that there is some disc swelling and it's not all normal. So for this patient, when we did the mutation, he had the 14484 mutation of LHON. And of course, when you have a patient, they want to know what's going to happen to them. So what is the natural path of LHON? They start to have like a subacute vision loss and over 3 to 6 months. So this is the peak of the disease, which we call nadir of the disease. This is the stage where the patient have the worst vision. Then over 1 to 2 years, they start to recover. So some of them recover, some of them do not recover. And we're going to talk about why some of them do not recover. What are the prognostic factors for Leber's patients to recover? One of them is that the type of mutation. So if you have the 11778 mutation, only 4 to 8% have spontaneous improvement. And most of those patients will fall into the category of severe vision loss with a vision of 20/200 in both eyes, sadly, because it's the most common mutation. And the other mutation, which is the 14484 mutation, this is the best prognosis. This is an MCQ question, always comes in the MCQs. And when we have the 3460 mutation, 36% spontaneous improvement. And what we have here is a patient with LHON. And as you can see here, the visual field, he had some sort of secocentral scotoma expanding a little bit. And then after 4 years, this secocentral scotoma resolved, and he had only just a little bit of residual central scotoma. Significantly, the vision moved from legally blind, which is 0.05, to moderate vision loss, which is 0.63 after he resolved. What are the predictors of visual prognosis? If you have a patient who is young and he converted to disease status at young age, he has better visual prognosis. Type of mutation, we said in the last slide that 14484 mutations have better visual prognosis and spontaneous recovery. The less severe reduction of vision at the peak, which is the worst stage in the disease. So those patients, if they have less severe vision loss at that stage, it found that the spontaneous recovery or the visual prognosis for them is better. Next, we have the investigation part, but Dr. Majid, if you have any comments, would be happy to stop here as well.
Yeah, Dr. Nuran, let's talk about how can we help general ophthalmologists to think about Leber's hereditary optic neuropathy at the clinical settings. And before we open the discussion together, I would like to highlight some of the points that you have mentioned. Number one, as we know that labors nowadays in the literature is classified into almost 3 stages. The stage 1 or the subclinical stage or the carrier stage, where the patients have the gene mutation, but he does not show the disease. And as you highlighted clearly, sometimes there is a clear triggering factor, as like smoking or sometimes drinking alcohol. So if anyone has a family history of labors and he's a carrier, he should be clearly educated and counseled about avoiding triggers for the hyperoxidation. Second is clearly you highlighted that the presentation usually like subacute and the duration from weeks to up to 6 months, and it's called nadir time. And this is the time that most of the patients usually present to the general ophthalmologist reporting visual loss, which could be sometimes unilateral or sometimes bilateral. At the early stage of the disease, you highlighted clearly, sometimes some patients will be labeled as malingering. And the reason why that most or good, no, not most, I mean good number of patients with labors, they don't have afferent pupillary defect due to the spare of melanopsin cells during the attack of optic neuropathy. So my point is, when an ophthalmologist should suspect, from your point of perspective, when he should think about labors at the clinical settings?
Usually what I do, and I insist to do in all patients that, and I'm going to mention in investigations, I take the history, I have some clue from the history, but as we said, most of patients will, or half of the patients might not have positive family history. So I don't really rely on the positive family history. What I do is that from the clinical presentation, if I have a young patient with bilateral subacute vision loss, and especially if I do the visual field and I see those central scotoma, secocentral scotoma, or just diffuse visual field loss, I like to order all the panel to rule out toxic nutritional, rule out demyelinating disease. And as you know, Dr. Majid, of course, most of those patients at the beginning, they get treated with steroids, treating them as demyelinating disease, because we cannot be sure that they are not demyelinating disease at the first stage. And then we end up, after ruling out all the differential diagnosis, then we end up by saying maybe it's something genetics. Let's look at the genetics. So the idea from today's lecture is to have that thinking of, yeah, I did everything else and all negative, let's do genetics. And also be careful from labeling the patient as functional visual loss, because if you cannot, or you think your knowledge is like, this is the maximum that you can do for the patient, and you investigated them, everything is normal, just do not label them as functional, because funny thing, in the literature, 50% from those who are labeled as functional, they actually have an organic cause. So for me, I fear to label the patient as functional, and I don't find something, I eventually try to tell them, okay, go to this person, they might be able to see or think. And if the other person agreed that, yeah, this might be functional, then it's like a two-step authorization thing for me. It's not just easy as, yeah, this is functional. Once you label the patient as functional, other ophthalmologists might think, yeah, this is just a functional, and dismiss the patient. And when it's like the patient, so the first thing with labeling them as functional, it's the parents will start to look for stuff that maybe there's some stress in the family, maybe we're doing something wrong. And the other thing is that they're gonna stop looking for something or a solution. So it's really difficult to do that. This is kind of like my input on the LHON patients.
Perfect, totally agreed. I would like also to add some points here. As you know, that the most common cause of optic neuritis in young is the demyelinating optic neuritis. And according to ONTT trial, that 92% of patients report pain with eye movements. So if there is a lack of pain with eye movements, this somehow for me raised the suspicion of other types of optic neuropathy, although if the demyelinating becomes so posterior enhancement like prechiasmal, usually patients they don't have pain, but lack of pain is somehow an alarming symptoms for me during history taking. Second is the triggers, like patient being a smoker or alcohol drinker or heavy alcohol drinker. This is another somehow I put it like a collective data to add to my history. Third is you highlighted clearly about the fundus exam. Labors, although not all patients with labors show it, is the presence of mild disc swelling with tortuosity of mid-arteriolar size, blood vessels within the retina near the disc. Third point is the color vision. Labors tend to affect the color vision, but the demyelinating optic neuritis tend to be, the color vision loss tend to be out of proportion of the visual acuity. And the third point is the doing the visual field testing. Upon doing visual field testing, the patient with optic neuritis, the most common type of visual field defect is generalized depression with general with central involvement, which could be the case also in labors. But if it is bilateral pathology and involving only the center, you should keep this in mind, as ONTT showed that only 8% of patients with optic neuritis might present with isolated central or secocentral scotoma. And one other point is the being bilateral pathology, as you highlighted clearly. This also raised the suspicion of Leber's hereditary optic neuropathy. And one more point to add is the lack of, and you highlighted this clearly, that lack of family history does not rule out hereditary type of optic neuropathy. So in one study, it has been shown that about 57% of patients, they denied a family history in Leber's hereditary optic neuropathy. And last thing, we have to keep in mind that Leber's still a rare disease, but it's still there. We should keep it in mind. And you mentioned clearly that lack of improvement, then involvement of the other eye after a few weeks. Patient did not show like or did not feel any improvement with steroid treatment. This raised the suspicion of Leber's hereditary optic neuropathy. Just wanted to stress on those points so that the audience can somehow digest when to think of Leber's. We can proceed to the part of investigation, Dr. Noran. Thanks.
Okay. So just a little bit of mentioning some of the ocular investigations that we do for Leber's and what we can find in them and how we can utilize them. And then I'm going to also mention some of the systemic investigations that I usually do in the process of detecting a Leber's. So OCT or NFL, well, we can utilize this when we have actually disc swelling and non-normal fundus. The most areas that they suggested in the studies that we will have some elevation or thickening is the inferior temporal. So this is more sensitive or specific to LHON. So looking at this area here, like in the case that I mentioned before, and at the late stage, which is a chronic stage, we can see that there might be some temporal thinning in those patients, but this is a chronic stage. How can we utilize retinal ganglion cell OCT? I find it very helpful if you have this diagnostic method to utilize it, because as we said that some patients are thought to be malingering, especially that the fundus is normal, the OCT RNFL normal, and all the investigations are normal initially. So the retinal ganglion cell, if you have a patient presenting with one eye with Leber's, and you think of demyelinating and the MRI is normal. So the utilization of it, that it can show damage or it can show pre-RNFL damage as soon as within weeks, whereas the RNFL can show the thinning after months. So this is one instant that we can use it just to have an idea that, yes, we do have damage in the OCT ganglion cells. And in some studies, they also showed that even if the patient lost the vision in one eye, the retinal ganglion cells will be affected. But even in the other eye that did not show yet manifestations of the disease, it might be affected at that stage. And as Dr. Al-Abailan mentioned, that when we have a unilateral disease, at the beginning, when you do the pupillary examination, it's going to be normal. And then the raise of the question whether this patient is malingering, because there's no APD. And that is specifically because the melanopsin retinal ganglion cells are the ones who are responsible for creating the APD, and those in the Leber's are spared. So we do not have APD. So this is just a suggestion to utilize the retinal ganglion cells if you have it more often. Leber's patients can have basically any visual field defect, the common being central sequocentral scotoma, but they can present with enlargement of the blind spot. They can present with the central sequocentral scotoma. They can have a diffuse central scotoma, quadrantopic visual field defect, hemanopic visual field defect, constricted visual field defect, or just a diffuse visual field defect like the ones that we see in the demyelinating optic neuropathies cases. This is one patient, and so here's the trick. In each stage, also in Leber's, you might see the patient changing in their visual field. So it's a hint that, yes, maybe this is a Leber's. And in each eye, they might have different visual field defects. So in the right eye, in this patient of mine, he has a central scotoma, and then at the nadir or the worst stage of the disease, he had like a hemanopic visual field defect. And in his left eye, initially nothing, because the left eye was not affected, then a small central scotoma, and the nadir of the disease, he had some sort of like a diffuse central visual loss. So what do we do? Usually, we have to come back to the basics. Basics, if we have a central scotoma, sequocentral scotoma, either swollen disc or normal or pale disc if the patient presented late, we have to go by the book. So even if there is a family history, but not confirmed LHON, you do not know that this is LHON. So you have to give the patient the benefit of the doubt that you need to treat him systemically. So systemically, we usually think first, as Dr. Majid said, demyelinating disease. So things that we want to rule out, that this is not a compressive etiology, this is not toxic nutritional, as it presents the same way with papillomacular bundle being affected first in the disease, and they have the central sequocentral scotoma. So we ordered the toxic nutritional panels, demyelinating disease, especially in the atypical male. We think of so we think of NMO and MOG disease, and we ordered the antibodies. We think of infectious inflammatory causes, so syphilis, TB, sarcoidosis, and we do order chest X-ray, ACE, ANCA, and troponomal screening. So this is what I usually do. And then when most of those patients at the beginning, they end up by taking steroids, thinking that this might be a demyelinating disease, as this is the most common. And then when everything is negative, I try to keep at the back of my mind, yeah, maybe it's something that is hereditary optic neuropathy. Let's order first the mitochondrial, and then if it's negative, we might order the West, the whole exome sequencing. Did you want to add something, Dr. Majid, to the investigations? Something that you do for your patients specifically, other than this?
No, actually, you highlighted the important points clearly, especially the early changes in the OCT. I want you to catch the time, so I will not interrupt your lecture. I will leave my comments at the end, okay?
Okay. So with regards to the management, what can we do for those patients usually young and very active in their life? Everything in green works from the literature review. Everything in red does not work. So lifestyle modification, yes, stopping smoking, marijuana, and alcohol works for the affected patients in terms of giving them the chance to recover faster or recover to a better visual outcome, and works for the carrier to emphasize, if there's any family member, that to stop smoking marijuana or just regular smoke and alcohol. Vitamins do not work. Coenzyme Q10, the first generation, does not work. Topical brimonidine was tried and from the literature does not work. Cyclosporin A does not work. Topical elampridine, which is a mitochondrial targeting peptide that is supposed to promote ATP and decrease the reactive oxygen species, does not work. Idebenone does work from the studies, and we're gonna kind of like highlight some of the studies on idebenone later. Epi 743 works, however, very little information in the literature, or little patients have tried this, so I don't have strong evidence on it. So the surprise is that gene therapy, I left it in gray because I'm gonna kind of like say something about gene therapy that is somewhat new. Idebenone was approved for LHON in the 1992, and it's a synthetic short-chain benzoquinone. It's a second generation of coenzyme Q10. What differs from the first generation coenzyme Q10, which we find in the pharmacies over the counter, is that the second generation is hydrosoluble, so it's able to cross the blood-brain barrier, and this is how we think that it's sufficient to improve the vision in LHON. And basically, from the idebenone, it aims to improve the mitochondrial respiration, reduces the stress on the mitochondria, and it inhibits or delay the retinal ganglion cell death and apoptosis. So this is how it works. I'm just gonna, before digging deep in the mechanism of idebenone, just mentioning one of the first case that I saw in the clinic. He was a 16-year-old male, painless vision loss in the right eye over 1 month. And this is when I came back to Saudi Arabia. He had a history in the left eye, vision loss 2 years back. So first thing first, yeah, maybe this is demyelinating disease. So his examination was 20/200. And after a few visits, he ended up being counting fingers. At first presentation, his fundus was normal. He had normal color of the optic disc in the right eye, which is the second eye. And the left eye, if you really dig deep and pay attention, you will notice a temporal pattern, very subtle temporal pattern. And when he came to me, he already seen a few ophthalmologists who said that this kid is malingering. And if you see the kid, he has that type of ADHD personality, and you kind of like sense that maybe he's malingering. However, with the mild temporal pattern, I'm like, maybe he's not malingering. And I also saw him in the waiting area. He was trying to kind of like read from the phone, and he does not know me. So he's like trying to put the phone here. Why would he do that if he's malingering? I ended up ordering everything: MRI, orbits, brain contrast, toxic nutritional workup, as I said, and the demyelinating disease workup, and everything turned out to be negative. And to be honest, I wasn't really sure, should I order the LHON mitochondrial panel? I'm like, okay, this is the only thing that is left for me to order. So I ended up ordering it. Meanwhile, I started the patient on the steroids and did all stuff by the book, and he did not improve. So he ended up, as a surprise, that he had a 11778 mutation. And I really was like, really, it was positive, because when I ordered it, I just put it in as, let's complete the workup. Let's see if he has something. But I was in doubt that he would have something. Okay, so this kid had this mutation, and he was started on the idebenone 4 months after the vision loss in the right eye, which is the second eye that lost vision. And the best corrected visual acuity 10 months after the idebenone was, for a surprise, 20/40 after being counting fingers in the right eye. And even in the second eye that had vision loss over 2 years, he had a vision recovering to 20/50. So this is very beautiful for me. It was really emotional when his mom told me that now he can resume his studies, because last year he was staying at home, he couldn't study. So now he's going to return for the next year to finish his school, and hopefully he has a wonderful career work. Okay, let's talk a bit about idebenone, what it does. So what it does is that basically it's like a shuttle or like a bus for the electrons. So it bypasses the dysfunctioned complex 1 and transfer those electrons to complex 3 directly. So increases ATP production in the retinal ganglion cells, and also it reduces the reactive oxygen species that triggers the cell death. The RUDO studies is the Rescue Hereditary Optic Neuropathy study. This was the first study that had 2 arms, double-blinded randomized placebo arm with the taking the idebenone, and the other arm was just observational. And in those 85 patients, the vision loss was less than 5 years from the LHON, and they had all 3 mutations. They took the idebenone only for 6 months, and after 6 months they measured the visual acuity, and they found a trend into improvement in best corrected visual acuity in the idebenone group. They wanted to know if this effect will continue after stopping the idebenone, so they did a RUDOS follow-up study 30 months after the RUDOS, and they found that this improved vision after they stopped the idebenone, it actually maintained. Another study was a retrospective study about the idebenone. They included 103 patients, and the follow-up was after 4 and 5 years. So in this study, they found that there's increased frequency of recovery of visual acuity. As you can see here in the graph, the green is the patients who took the idebenone, and the purple is the patients who did not take the idebenone. So it was significant improvement in the idebenone group. And they found that early start of the therapy of the idebenone was a very strong predictive factor of the end visual outcome. Another interesting thing that a lot of people will ask is that, so if a patient presents with monocular vision loss and we started the idebenone, does it really stop the progression in the other eye? No, it does not. They found that if a patient presents with monocular vision loss and they started the idebenone, it does not stop that eye from going to nadir. However, it delays the onset of the vision loss in the other eye. So what is the dose of idebenone? Is 300 milligram per oral TID for 1 to 2 years. And we started at least 1 year. This is the recommendation. Started at least 1 year from the vision loss in the second eye. So what about chronic LHON? Patient lingering here and there. Ophthalmologist doesn't know what to do with this patient. Every investigation is normal. So if we discovered that he has LHON and it's more than 1 year of the vision loss in the second eye, what do we do with those patients? So this study kind of answered that question. To be honest, it's a small population, 7 patients only in 14 eyes, but the vision loss was from 5 years up to 51 years diagnosed with LHON and vision loss. They gave the idebenone for 1 year, and the results were impressive somewhat, because those patients have significant improvement in vision by 10 ETDRS letters, and visual acuity improved more than 2 lines in 7 of those eyes. The mean deviation in the visual field was not significant. However, we can see that there's a trend of improvement from the numbers alone. Dr. Majid said that this disease affects color vision to some extent. So does idebenone improve color vision? So this study took the patients who took idebenone for 24 weeks and measured the color vision, and they noted that there's the treatment with idebenone improved the tritan yellow-blue color vision compared with placebo, and it was significant. And there was a similar trend of improvement in the red-green also portion. However, it's not clinically significant. Do we treat carriers? So yeah, one patient you have having LHON, and the family asks you, okay, what about the brothers and sisters? Do we give them idebenone to stop the progression? No, it's not recommended because not all carriers will manifest the disease, and we don't have strong evidence that idebenone will stop the progression. And just the recommendation for them to stop smoking, alcohol, anything that causes the mitochondria to stress out, just stop that, but no strong evidence to give them idebenone. So if you kind of lost track when I was speaking about the idebenone, this is the summary slide. We're just going to touch back. Improvement of vision. So idebenone improvement of vision and statistically significant improvement. There was a trend of improvement in visual field, not statistically significant. There was improvement in color vision, especially the yellow-blue. And the effect was maintained after stopping the medication. It does not prevent the vision loss in the other eye if we started it with monocular vision loss in those patients. It just delays the vision loss in the other eye. The recommended dose is 300 milligram TID for 1 to 2 years. In chronic LHON, yeah, you might offer it to the patient. We need more studies on that. Carriers of LHON, do we treat? No, we don't treat. Just a little bit about gene therapy. We have those gene therapy studies. Gene therapy was targeted to the 11778, which is the most common. We have the rescue, reverse, restore, and reflect. Rescue and reverse treated unilateral eyes, and they found that treating unilateral eyes with the gene therapy improved bilateral. Restore was basically just a follow-up at 5 years post-injection to see if they maintained the vision improvement, and yes, it was maintained. The reflect was basically, do we treat bilateral or unilateral? Is there a difference? And what they found that there's a trend towards bilateral being more significant improvement than unilateral. However, statistically, it's not significant. So the surprise. I just knew in April of 2023 that the gene therapy trials are no longer active as for that date. It's not that they discovered something harmful from the gene therapy. It's just that they do not have enough data to support the funding to continue with the management with the gene therapy. Last thing, I'm going to close up. This is a case that I saw during the fellowship as well. She's a female, 16 years old, with a rare variant of 14568 mutation. At presentation, she was already an idebenone because she had a maternal uncle who had LHON. So she presented with monocular vision loss 20/70 in the right eye, and she had 14/16 color vision. And as Dr. Majid highlighted, that in demyelinating disease, usually the color vision is disproportionate to the vision loss. And we do not see that here. It's just a mild affection of the color vision at the initial presentation. At nadir of the disease, which is the worst stage of the disease, she had counting fingers of 1 meter in both eyes and 0 color vision. At 2 years, when we examined her, she had 20/20 vision, 14 out of 16 in the right eye color vision, and 16 out of 16 in the left eye. And this was a really good moment because she was able to also resume her activities as an athletic swimmer. So it was a really good moment. Just reviewing her visual field. So at presentation, she had a small central scotoma in the right eye. Then at the nadir, she had the diffuse visual field loss in both eyes. At the last follow-up, where the vision was 20/20 and the color vision improved, as you can see here, she still has those areas of relative scotomas. So the theory is that in LHON, when they recover, they have windows of clear vision in between relative scotomas. So it kind of explains why she has this good vision and color vision. And this is the last slide. In summary, if you have a male aged 15 to 30 years, painless vision loss, one eye affected initially, followed by the other eye, pseudodisc swelling or thickening in the RNFL, positive family history of LHON or optic atrophy, with all the negative systemic workup and non-responding to steroids, think of LHON. And another time, I'm just going to put it, biologic diagnostic program for those who came late will offer actually free testing for LHON mitochondrial genes, and you get the results in 25 business days. This is the information card for the biologics representative. Please feel free to take or capture the screen. Last thing is thank you for being here on a Saturday. It's your weekend. I'm sure that each one of us has a role in treating and, first of all, diagnosing those patients who linger from ophthalmologist to ophthalmologist, not knowing their diagnosis. So as little as just informing them about what they have is important, even if we couldn't give them the 20/20 vision that they want to regain. Dr. Majid?
Yes.
Do you have any comments? This is the last. I'm just going to put the last slide as this, so anyone who didn't get the chance to get the information, they have it.
Thanks, Dr. Noran, for this informative lecture and the new updates for labor optic neuropathy. Basically, so it's clearly now for general ophthalmologists or colleagues who specialized in other than neuroophthalmology, that LHON is not anymore a male disease. It's not anymore that does not have treatment. There are some treatment attempts in the literature, and Dr. Noran Bahdeeb highlighted clearly the treatment attempts. We have some questions from the audience, and we could put them at discussion. We have a question from one of the colleagues saying, in unilateral LHON, is there any way to detect any abnormality in what looks normal in the contralateral eye? So the question again, Dr. Noran, is there any finding that we can look for in the other eye if one eye got involved with LHON?
If the patient is going to develop the LHON within 6 weeks as the typical presentation, so one eye gets involved and 6 weeks later the other eye gets involved, some studies show that the retinal ganglion cells in the normal eye are affected at the initial stage, even before that manifests actually in terms of vision or color vision. So visual functions are normal. The patient is not complaining about that eye, only one eye, but initially you might find some retinal ganglion cells being affected in that eye. So this is what I know. The others investigations, I am not sure if they will be affected. It's only the retinal ganglion cells that showed affection. I'm not sure if Dr. Majid has another opinion or experience.
No, actually already mentioned some of these points. Basically, the other eye exam might be normal upon fundus exam. And sometimes if you are very careful in examining the other eye, you might see very minimal disc edema without visual loss upon fundus examination with tortuosity of the mid-arteriolar blood vessels, because this might present as a disc swelling without, as you said, functional visual loss. The second point you mentioned in your OCT investigation, that OCT can help in showing thickening at the inferotemporal fibers, and you showed that clearly upon the investigation slide. Plus, sometimes you said, you also mentioned that you might see a ganglion cell layer loss at the papillomacular bundle, which could be very early and subtle in the early disease. So there is one question said, if you are going to do MRI, is it with or without contrast? So the answer is always we should do MRI with contrast. And the reason why is you want to see if there is a point of hyperintensity, whether it's enhancing or non-enhancing, to see if it's like an active pathology or an old disease.
Yeah.
One question from the audience, is Idipinone available in the pharmacy in the Saudi Arabia? To probably clarify this point, Idipinone, the brand name is Raxon. It's a derivative of coenzyme Q, and it used to be sold outside the kingdom as a food supplement, but the company they have like a special formula, and we don't know it. To improve the, as you said, Dr. Noran, before, the penetration of the medication to the mitochondria. All of us, if we read the textbook, it says give coenzyme Q10. The coenzyme Q10, if you give it to your patient, they will have antioxidant in good level in their serum or blood, but it cannot penetrate the complex 1 to complex 3 within the mitochondria, and the Idipinone has the capability of penetrating to the complex 3. Is it available if you to give it as a treatment? The sponsoring company now, they are working in getting the Saudi FDA approval, as well as they have a contact with the Ministry of Health to treat special cases needed before they finalize the paper of approval. Mm-hmm. There is another question saying, Dr. Noran, for how long you will give Idipinone to your patients? Is there any clear literature?
Yeah, sure. It's clear. So just one thing for the MRI, the MRI with contrast is basically ordered to rule out demyelinating disease or a tumor, anything else. So it's to exclude, to say, yeah, this is normal, and to pinpoint that this is LHON eventually. So it's to rule out. But for LHON, it's going to be, in most cases, normal. Yeah, sure. So with regards to the duration of Idipinone, we give it for 1 to 2 years, because we have from the international consensus of LHON guidelines, they agreed that the period to give it is 1 to 2 years. However, they suggested if any other physician feels that they wanna, or the patient wants to continue on the Idipinone, there's no harm. However, they don't have any strong data to back up that you should continue on Idipinone for life.
Yeah, and to just add one point, is there any adverse reaction from Idipinone? There have been some studies said there is no significant adverse reaction apart from some GI symptoms like diarrhea.
And it's so some like to order kidney functions and liver function. If the patient was on Idipinone for a long time, it might affect, but until now, it does not cause any harm. So in the literature, as you said, there's no side effect, but we might just need to order it, after like a period of 6 months from taking the Idipinone, because it's excreted through that pathway.
Perfect. One more question, is B12 contraindicated in LHON?
No, it's not contraindicated. Are you aware of any contraindication for B12 and LHON? I have not came across that, no.
No, actually, even me, I did not came across that it's contraindicated. Yeah. I think really we answered most of the questions.
There's just one about
the question saying, what is the incidence or prevalence of LHON in Saudi Arabia?
You don't know.
Actually, there is no national study stating the incidence. Yeah, even internationally, it's 1 to 50,000 of carriers. Yeah, of carriers. That means that there are like many carriers, but they don't show the disease. They don't convert their mutation to a pathology.
Yeah. So the prevalence internationally, it's 1 to 50,000 affected. And for carriers, if you take a 1,000 person and you did the screening, you'll find one of them in each 1,000 might have the carrier mutation. But in Saudi Arabia, we do not know the incidence or prevalence because we still need to build up our data. As the gene testing is somewhat new, I don't know. I'm practicing just for 1.5 years now, but I think like the gene mutation detection has been available only for a few years now.
Correct.
Yeah. So
I think now we could reach a conclusion. First of all, I would like to thank the Saudi Ophthalmology Society for organizing such webinar with the sponsoring company. Thanks to all the audience who joined us in this evening in, as you said, like a family time of Saturday. And thank you so much, Dr. Nouran Bari, for preparing such a great lecture. We are lucky to have you in the Ophthalmology Society in Saudi Arabia.
Thank you very much, Dr. Majid.
I think we can conclude. Thanks, everyone.